Did you know that heart disease kills more women than all cancers combined? In fact, this is the truth. Primarily to let us remember that it is not only a man's disease, but very much every woman's disease too. So this is the data looking at American women in 2000. The leading killer of women at all ages is still heart disease. 1 of 3 women dies from heart disease and is the #1 killer of women regardless of race and ethnicity. It also strikes at younger ages than most people think, and the risk rises in middle age. And 2/3 of women who have heart attacks actually never fully recovers. You will see here breast cancer only ranks #4. Okay, so if you want really numbers, so we have that data too. In 2001, cardiovascular disease claimed the lives of 498,000 females, while cancer only took 266,000 women. 38% of women compared with 25% of men will die within 1 year after a heart attack. And if you talk about stroke, 4.8 million stroke survivors alive today, more than 50% are women. So there are still misconceptions that exist that cardiovascular disease is not a real problem for women. In fact, still cardiovascular disease ranks first among all diseases categories in hospital discharges. It is CVD and stroke that remains the leading cause of death, not only in the US but also in other developed countries. So that 1 in every 2.5 women who die of heart disease, stroke, and other cardiovascular disease versus 1 in every 30 die of cancer. So it is also important to emphasize that the risk of cardiovascular disease increases with age. It is important to raise this major public health issue for older women, so that, as I've said, prevention of CVD is the best practical solution. So this is our data in the Philippines. Dr. Abanilla emphasized earlier that disease of the heart, disease of the vascular system ranks 1 and 2. This is the number of women died of heart disease and cardiovascular death that comprise about 40% of the total mortality. This is a 2004 data. So in the Philippines, cardiovascular disease is a leading cause of death among Filipino women. They differ from men. They have higher incidence of heart disease, hypertension, obesity because of their unique menopausal state. Furthermore, there are reports that Filipino women may be less aware of the cardiovascular health risk, have less concerns for their own health, and less likely to report CV signs and symptoms. And this is quite evidenced by the Project EVA. Have you heard of the Project EVA? Okay, so this is done here in our country, particularly in the Metro Manila area, in the evaluation of the knowledge, attitude, and practices of Filipino women in Metro Manila with regards to cardiovascular diseases and risk factors. So this is a joint project with Philippine Heart Association, Council of Women's Health, the DSWB, and the DOH. This data will be useful so that we'll be able to improve the knowledge, perception, and behavior of Filipino women regarding cardiovascular health. So what is the objective? Primarily to assess among Filipina their knowledge on heart disease, stroke, and their risk factor, and look at the lifestyle and attitude of such women. So what's the result? Well, surprisingly, they have the same result as that in the other countries. So the perceived leading cause of morbidity among Filipino women is cancer. So that is how they perceived it. Only 15% perceive cardiovascular death as a cause of morbidity. If you talk about mortality, women also perceive still cancer ranks #1. Second is only cardiovascular death. So if you look at the data, you have 65% of the respondents responded to the EVA belonging to the socioeconomic class of D and E. The rate is low compared to the Philippines, where 76% belong to these classes. Only 13% belong to the class A, B, and upper C. Generally, 52% have graduated from college and had some college education, while 20% on the national average. Hence, it can be hypothesized that knowledge, attitude, and perceptions towards cardiovascular disease may be worse, particularly people outside of Manila. 80% of Filipino women in Metro Manila are not aware that cardiovascular disease is the leading cause of death in the Philippines. They recognize nutrition and exercise as effective measure to preserve cardiovascular health. They did not look into cholesterol or smoking and other risk factor as one thing that they have to look into as part and parcel of prevention of cardiovascular diseases. So are women really different from men? Are we? Yes, definitely. It is because primarily women minimize their cardiac symptoms. So classic heart attack symptoms are typical in men, such as crushing chest pain, cold profuse sweating, nausea, pain related to the neck, the usual thing that we see in the book, right? But for women, they are more of complaining of profound sense of fatigueness. They don't actually complain of chest pain. Madali akong mapagod. I have shortness of breath. There are flu-like symptoms, abdominal discomfort, symptoms that may be there for the past days. So typically, weeks before heart attack, 94% of women will have these signs and symptoms. Again, unusual fatigue, sleep disturbances, shortness of breath, indigestion. Only less than 30% had chest pain. Now, at the time of their heart attack, they usually still have to be complaining of shortness of breath, fatigue, weakness, less chest pain. Okay? Also, women seem to be toughing out more than men. And studies have shown that men and women have the same severity of disease, but women would be saying it's just mild to moderate, not severe. Hindi mareklamo as that of the male, right? This keeps women from getting the quick and thorough follow-up care that they need. Now, there is also gender differences in atherosclerosis. Women suffer plaque erosions as compared to men who have plaque explosions, leading to more acute coronary syndrome, such as unstable angina, non-QMI, making the diagnosis more difficult and leading to delays in treatment. They also have known to have very small coronary arteries. They can seriously affect the symptoms from anything that reduces diameter, such as stenosis, or even endothelial dysfunction. They also have a different way of remodeling, that is what you call your outward or positive remodeling. This is an atherosclerotic lesion, but that protrudes outward rather than impinging into the lumen. So most of these changes, as we said, are seen specifically when women start to experience menopause. Because in menopause, you see a lot of changes not only in their lipids, the prevalence of hypertension or metabolic syndrome, or even their risk factors such as triglyceride, diabetes mellitus, obesity, or even their waist circumference changes as well. So in summary, if you look at cardiovascular disease, these are the differences in presentations in women compared to men. Although there is lower prevalence of MI, when they have the heart failure, it is more severe. They have difference in terms of symptoms, less angina. If they have angina, it is quite more severe. If you do a coronary angiography, it may be less angiographically significant. They have more osteal lesions. They say because of that very small arterial diameter, more endothelial or microvascular dysfunction, abnormal vasomotor tone, and more endothelial dysfunction. So the American Heart Association guidelines has given ways to which we'll be able to be guided in terms of preventing cardiovascular disease in women. And they coined it as aloha to heart disease in women. So when you say aloha, it means goodbye, right? So when we talk about aloha, we don't want heart disease, okay? So A stands for assess your risk, whether you're high risk, you're moderate, or intermediate, or low. L stands for lifestyle recommendation, which should be your first priority. O stands for other interventions prioritized according to expert panel rating scale. Your H, the highest priority for therapy for women at higher risk. And lastly, A, avoid medical therapies, which are called class 3, where evidence is lacking that would be beneficial to you. So what are the risk factors? So this is the same risk factors as what we see for men. We also divided into controllable and uncontrollable risk factors. So controllable, these are your cigarette or tobacco smoke, high blood cholesterol, high blood pressure, physical inactivity, obesity, and overweight. So this is where we will intervene. Of course, the uncontrollable, we cannot do anything about it. Increasing age, the sex, family history, and of course, the evidence of menopause. So how do you assess your risk? You are considered high risk if you have already established coronary heart disease, meaning you had an MI, you had a stroke, you had an angiography done, it shows stenosis, you had an intervention. Patients who have peripheral arterial disease, if you have abdominal aneurysm, you have already end-stage renal disease. If you're considered high risk, if you're diabetic, okay, or if you have a 10-year Framingham global risk of more than 20%. So the risk that we've shown you earlier, the controllable risk factor, you have to count, okay? Because 2 or more of this would tell you that you're probably intermediate or moderate risk. So if you have less than 2, then you are low risk. And last, of course, L. So A, assessment of risk. L is lifestyle change. So the first line defense against heart disease, this is a class 1 recommendation. If you're a smoker, you have to stop smoking. If you're a second-hand tobacco smoke, you have to walk out. Leave your husband, leave your boyfriend. No? Get at least 30 minutes of physical activity, preferably or most days. Start a risk reduction or cardiac rehab program. If you had recent ACS or stroke, eat a heart-healthy diet, maintain your healthy weight. So how is this being done? Of course, smoking. The risk of heart attack is more than twice than that of the non-smoker, right? In fact, it is the biggest risk factor for sudden death. And this is one risk factor that was neglected in EVA. They did not recognize smoking as a risk for cardiovascular death. Chronic exposure to environmental tobacco may increase even risk of heart disease. Now, what are the essential components of a healthy diet? Dr. Reyes already mentioned that it's not only in during childhood, but also when you go into adulthood, you have to decrease saturated fat. Okay? Increase your dietary and supplemental fibers, so high fiber breakfast cereal, supplements, so forth. Plant sterol stanols, 2 grams per day. Added yogurt to other food. Soy protein, flavonoids or nuts, weight loss and exercise. So choose fats and oils with 2 grams or less saturated fat, such as margarines, canola, olive, corn, sunflower, or soybeans. Limit intake of food high in calorie, low in nutrition, including foods with a lot of sugar, such as soft drinks and candies. Limit foods high in saturated fats, such as full milk, fatty meats, tropical oils, or partially hydrogenated vegetable oil. So 5 servings of fruits and vegetables, variety of grain products such as whole grains, choose 6 or more servings per day, eat more fish twice a week, such as mackerel, tuna, salmon, sardines, because they have very high free fatty acid. You should include fat-free and low-fat milk products, more legumes, beans, skinless poultry, and lean meats. Now, it has been known also that vegetarians have lower BP than meat lovers. So increase your fruits and vegetables would be able to reduce your blood pressure by 3 millimeters mercury, while additional reduction in fat intake will reduce by 6 millimeters mercury. The intake of fish also enhances BP reduction, specifically in obese, hypertensive, and patients who have very high BP profile. Salt is also one characteristic that we have to be focusing. Eat less than 6 grams of salt or sodium chloride per day. That is equal to 1 teaspoon of salt, or a daily sodium intake of less than 2,400 milligrams, because it will be able to reduce your BP, systolic BP, by 4 to 6 millimeters mercury. Obesity and overweight, now it has been very well correlated to the development of heart disease and stroke. It is unhealthy because excess weight increases strain to the heart. It is directly linked, as I've said, to coronary heart disease because it influences blood pressure, cholesterol, and makes individual more prone to diabetes. Now, exercise tips. Water has always been emphasized. So if we plan to be active more than 30 minutes, or if we plan to walk more than 30 minutes, make sure to drink water every 15 minutes, especially at this point in time. No, it's very hot and it's very humid. And specific instruction: as you age, your sense of thirst tends to decrease, and you can't completely rely on the internal sense of thirst. So even if you're not that thirsty, you have to drink more and more water. So what kind of exercise do you choose? Of course, pick activities that are fun, all right, that suits your needs, that you can do year-round. So you cannot do skiing in a place like this. You cannot run all the time if you're exposed to, very hot temperature. Of course, your clothing also has to be considered, or comfortable clothing when you do exercise. And you decide walking is a great activity for you, choose a place that is smooth, soft surface, not go to Mount Pinatubo, etc. No? So as I said, pick your rhythmic, repetitive activities that challenge the circulatory system and exercise at an intensity that is fit for you. Okay? So these are the health benefits of weight loss. It reduces cardiovascular risk, reduces glucose, so it reduces incidence of diabetes, it reduces your blood pressure, your cholesterol, even improves your sleep. And of course, for the aging population, it reduces the symptoms of degenerative joint diseases. What about stress? No? Managing stress also makes one's for overall health. Okay? Although there is no current data to support recommendation, reduction in stress is proven a therapy for cardiovascular death. No? It is an independent risk for cardiovascular disease, so both acute and chronic stress may affect other risk factors such as blood pressure and cholesterol levels as well. So let's go to O. So we're done with A, L, and then O. What are other interventions? So class 1 recommendations, so for blood pressure, cholesterol, and diabetes. So if you have high blood pressure, make sure that you have optimal level of BP, less than 120 over 80. Your cholesterol should have an optimal level of less than 200. LDL should be less than 100. With your good cholesterol HDL of more than 50, and the low triglyceride of 50 milligrams per deciliter. The recommendations for diabetes would be a control of your HbA1c of less than 7. And like before, it has to be less than 6. Now it's a bit high at 7. So 3 of every 4 women will have a high blood pressure, and they know they have it, yet out of 3 of them don't control it. So all women must take steps to control their blood pressure. So it increases workload to the heart that causes the heart to enlarge and weaken over time. That's why as early as detected, we have to control the blood pressure. So diabetes mellitus, it is seriously increased, not only in developed countries, but also in developing countries as well. It is being pinpointed as a risk factor, in fact, a high risk. If you have DM, it means you already have a CHD or cardiovascular disease. More than 80% of people with DM die, not of that diabetes alone, but on some form of heart or blood vessel disease. Now, alcohol. Now, they might say alcohol is good for the heart, but moderation of alcohol consumption, there is a linear relationship between BP and hypertension prevalence. It attenuates antihypertensive drug effects. However, heavier drinker may experience a higher BP after acute withdrawal. So ethanol limit should be between 20 to 30 for male, but for us, it's 10 to 20 grams per day of alcohol. So H, so A-L-O-H. H is highest priority for therapy for women at high risk. So we have listed out the different high risk women, those who have already coronary artery disease, who have stroke, PAD. Make sure that you have all of these drugs within your armamentarium unless there are contraindications. No? So ACE inhibitor, your aspirin, beta blockers, statins, warfarin, especially if you're in AFib. So last, your A, you're avoiding medical treatment, specifically those who have not been recommended. No? So one would be hormone therapies or your selective estrogen receptor modulators or SERMs. should not be used for primary or secondary prevention. Now, for those individuals who have menopause, early signs of menopause, and they have these hot flushes and all of these symptoms, you may use such kind of hormonal therapy, but only for a short course, okay? And last, antioxidant supplements, folic acid supplements, has not been proven to have any cardiovascular benefit in randomized trials of both primary and secondary prevention. So women now are making a change, so it's not only abroad, but also here in the Philippines. We recently launched the Alagaan Mo Ang Puso Ko last April 16. Okay, so these are the different members of the PHA Council of Women's Health. We were able to launch it. We had a show with Mr. John Santos, okay, heart-to-heart talk with Mr. John Santos. So just some healthy heart tips. Make sure that you involve other people in your way of healthy lifestyle. Get your friends and family to join. Make changes slowly in your family's diet and exercise habit. You share healthy cooking tips and recipes. Suggest that your church or community group hold blood pressure or cholesterol screening. Find a partner, so if that partner will not exercise with you, leave that partner. Joke. Turn off TV and do something active with your family. Help friends and family who want to quit smoking. Take action in your community and workplace. So ask for healthier food choices in groceries, so you have to have an active part, no? In choosing healthier foods in grocery stores, restaurants, cafeteria. Insist on non-smoking sections in restaurants or even other public places. Request your workplace to be smoke-free. Start a fitness walking club or exercise club. Knowing the warning signs of heart attack, we'll be able to discuss later on by our next speaker. So the heart truth, this is the Trust of Women's Heart Health Advocacy. And you see Ms. Vilma Santos is our general model for this campaign. So we wanted to create awareness among women at all levels that CVD and not cancer is the #1 killer of Filipino women through trying media, using the print, TV, and radio. Educate Filipino women through lay forums such as this, seminars and workshops. Encourage Filipino women to engage in healthy lifestyle, see their doctors, and drink their medicine. To break all cultural barrier that makes women's heart health a less priority than men. Enroll as many advocates among lay, non-health professionals, and the government. And to train physicians to educate women to close the gap between perception and reality of cardiovascular disease. So we should be riding a motorcycle with that on our head, so that we'll not die if an accident happens. It's not only sitting at the back, but probably leading the way, right? Because after all, S doesn't stand for Superman, but Superwoman. Thank you so much for your attention.